adult mental health units, emergency departments, alcohol rehabilitation units, and oncology units. Delirium is even affected by the time of day, with symptoms fluctuating and worsening at night. Now listen to this nurse-client interaction and see how many symptoms of delirium you can identify. A female client is brought to the emergency department of a general hospital by her parents. The client was in good health until 2 days prior when she felt very tired and developed a sore throat. On ED evaluation, she was very restless and looked extremely frightened. Her speech was garbled and incoherent. When approached by someone unfamiliar to her, she became very agitated and even tried to climb out of bed and strike out. She would sleep off and on. Admission vital signs were 104 temp, pulse 108, and respirations 28. Her skin was warm to the touch, and she was only drinking a few sips of water in the last 24 hours and not urinating at all. The client was uncooperative with the mental status exam. She was disoriented and responded to her name by turning her head. When the nurse asked where she was, the client said, "Home." She would only give the month when asked for the date and said it was January. The actual date was February 19th. She refused to give the day of the week. During one shift, the client became very agitated and tried to get out of bed, saying, "Bugs, get away, get away." The client started brushing and slapping at herself and the bed. The nurse encouraged her to calm down by speaking simply in a louder voice, calling the client by name and saying, "Alice, I don't see any bugs in here, but I understand how scared you must feel." Yet, periodically, the client continued to slap at the bugs. Lab tests indicated an elevated white blood count and an electrolyte imbalance consistent with dehydration. Throat cultures were positive for strep, so IV antibiotic therapy was started. As the infection improved and her fever decreased, the client's cognitive functioning became normal, and she was discharged from the hospital. Delirium, disorientation, rapid onset, impaired memory, personality changes, misperceptions of the environment, usually a result of trauma or seizure. Did you identify all of these symptoms? The priority intervention is risk for injury related to disorientation and confusion. Once again, safety is a priority in mental health, so planning for clients with delirium focuses on protection from injury. The client has or is at risk for physiological problems. Consider the earlier case study. What are the priorities? Physiologic needs include nutrition and fluid balance, and be sure to consider restraints for IV therapy because the client is very restless and agitated. Lack of sleep should be monitored because it can cause more confusion. And if your client is disoriented, the lighting in the room should be adequate because shadows can be misinterpreted and can add to the client's fear. Being able to identify environmental objects can promote orientation. For hallucinations, continually orient the client to the reality of being in the hospital, just as the nurse in our case study intervened with the bug hallucinations. Communication should be simple and clear, with minimal choices to avoid additional confusion. Without adequate intervention, delirium can become dementia. Dementia has a gradual onset. It includes a loss of intellectual ability with an impairment of memory, judgment, and abstract thought. Alzheimer's disease is the most common type of dementia. A common behavior seen with dementia is disorientation. Time is affected first, then place and person. Causes of dementia include Alzheimer's disease, vascular disease, HIV, head trauma, and Parkinson's disease. Confabulation is another behavior related to memory loss. As Alzheimer's disease progresses, clients can develop aphasia, difficulty finding the right word, apraxia, inability to perform familiar activities, agnosia, difficulty recognizing objects including people, and amnesia, memory impairment in the absence of other cognitive symptoms. Like delirium, symptoms of dementia often worsen at night. Clients with dementia may be labile, impulsive, restless, and agitated, especially at night, and disturbances can occur in attention, cognition, such as recent memory and disorientation to time and person, and perception, such as visual hallucinations and illusions. With dementia, education is focused toward the family members who are the client's caregivers, and nursing interventions consider the fact that clients with dementia are disoriented. So interventions are focused on helping the client participate in appropriate social activities and function as independently as possible in the environment. Here's an example of how the environment could look. Notice the large name sign on the client's door, a family picture on the desk, personal possessions nearby, a light in the room to keep the client oriented at night, the clock with a large face. It's not digital. That can confuse the client. And a calendar with large writing and a separate page for each day. As a nurse who communicates with clients who have dementia, you should introduce yourself at each interaction. Questions that require yes and no answers are best. Request behaviors one step at a time, and if you repeat an instruction, repeat it exactly the same way. Reminiscing is therapeutic, and pictures can help the client remember past experiences. As a nurse, you'll need to respond to wandering. Stress in the environment can contribute to wandering, so decreasing stress can be helpful. Eliminating distracting background noise is also helpful, and decreasing agitation is necessary. If a client refuses to participate in an activity, continued insistence can lead to increased agitation and sometimes to a loss of behavioral control. The early phase of dementia includes impairment of thinking, judgment, and impulse control, neglect of appearance and hygiene, and personality changes. The progressive phase of dementia includes irritability, moodiness with sudden outbursts, inability to address personal needs, wandering away, incontinence, and impaired remote memory. Confabulation develops to fill in the memory gaps. Let's summarize the interventions for a client with dementia. Decrease escalation with distraction like food, beverages, or music. Maintain consistency and routine in the environment. This will help reduce anxiety. Use photographs to help orient the client with memory loss. Communicate clearly and effectively with simple instructions. Administer medications as prescribed to treat specific causes of the disorder.
Examples of medications for dementia of the Alzheimer's type include Tacrin, Cognex, Donepezil, Aricept, Rivastigmine, Exelon. Consider that older adults need lower doses of medications. For lorazepam, Ativan, for example, a recommended dosage for older adults is 0.5 to 1.0 milligrams BID to TID, and for adults, it's 1 to 3 milligrams 2 to 3 times daily. For risperidone, Risperdal, an antipsychotic, the recommended dosage range for older adults is 0.25 to 2 milligrams daily, and for adults, it's 1 milligram twice daily, increased to 3 milligrams twice daily, and the usual range is 4 to 6 milligrams per day.
And remember the 5 R's: right client, right drug, right dose, right route, right time. Based on these interventions, what are some important client outcomes? Maintain self-care needs, avoid harm to self or others, experience increased orientation, improve verbal communication, participate in social activities. And that brings us to eating disorders. Eating disorders are most common in females ages 12 to 30. The 3 major types of eating disorders are anorexia, bulimia, and compulsive overeating. Remember what causes eating disorders? There can be biological factors such as biochemical imbalances. High levels of serotonin contribute to anorexia, and low levels are related to bulimia. Excessive amounts of the brain hormone vasopressin are associated with eating disorders and other obsessive-compulsive behaviors. Other risk factors include familial influences such as